I want to thank you very much for the invitation to come and speak. When I first got the invitation, I wasn't really sure whether this topic fit, but actually I hope it'll give you a good overview of kind of where this technology is, which has been very much in evolution, what its applications are, and how it fits into our medical system. So what I'm going to do is talk a little bit about what it is. What is ECLS? What does it mean? What are the different kinds of ECLS? I'll talk a little bit about the system components and the technology because they have evolved, and that has really affected both the adoption of this technology and the risks that our patients face. I'll talk specifically about indications and contraindications because patient selection is absolutely critical for this approach. It's resource intensive and it's resource limited, so it makes it challenging. I'm going to go through the evidence in adults. So this has been pretty well established in children, particularly neonates, for specific conditions. Children's Hospital here has a very active program. They do about 50 cases a year. But in adults, this is relatively new, and I'll share with you that evidence. I'll talk about some of the complications, which particularly impact, I think, our interactions with lab medicine. And then I'll give you just an overview of the UW Medicine program, both at the university and at Harborview, where that stands and maybe where we're going. So extracorporeal life support is kind of a catch-all term for a whole group of different approaches to providing life support to patients by basically taking blood out of the body, doing something to it, and putting it back in. And the strategies we're going to talk about today are primarily VA and VV ECMO. Let's see if my pointer works here. Up here, there are hybrid combinations, which I'm not going to spend a lot of time on. Those are pretty rarely used. And there are other strategies that just involve extracorporeal CO2 removal for respiratory patients. That's been largely studied in Europe. We'll look at a little bit of that data, but we're not going to talk too much about that. And then the really sort of frontier things that are being explored are using extracorporeal life support in the setting of ongoing CPR. Not going to dwell on that today. We're not ready for that. But it is something that is being explored, particularly in Europe. And then organ donation, again, that's something that people are exploring and as a way to support patients towards organ donation. That's pretty controversial, and I'm not going to talk too much about that. So extracorporeal life support, basically it provides either cardiac or pulmonary or both support for patients. And basically, it's the same equipment, it's the same approach, it's just how you cannulate the patient. So veno-arterial ECMO basically means you take blood out of the venous system, you run it through this pump, it oxygenates it, it removes CO2, and it puts it back into the arterial system. That approach is providing both cardiac and pulmonary support, and your heart can be in almost complete failure in that approach, and you can support the patient. Veno-venous ECMO is taking it out of the venous system, putting it back in the venous system, and that provides solely respiratory support. It's not providing any cardiac support. So if in that circumstance, it's used primarily for very bad respiratory failure. So the very first case of adult ECMO in the literature was a trauma patient. And honestly, if you had asked me even 10 years ago, should we be doing ECMO in adults, I said absolutely not. So things have changed. But this was an interesting case that was presented in the 1970s. You can tell maybe by the age of the vehicle here, of a motor vehicle crash. And this is the patient. This is at the University of Michigan, where Bob Bartlett, who's kind of the father of extracorporeal life support in the US, was experimenting with this approach, and this was one of the very early setups for ECMO. Let's see if I can show you here. This big thing here, this was the pump. It was a huge roller drum pump, and basically they drove the blood through there and back into the patient. You can see here that his PO2 curve, this is the arrow, is when they decided to put him onto ECMO. You can see sort of choppy improvement in that. Eventually, he was weaned off of that and survived, but a lot of people say, oh, he survived despite ECMO, because in those days, there was very high complication rates, very high rates of coagulopathy, lots of damage to the cells going through this aggressive roller pump, and a lot of bleeding complications. And so the history of ECLS has really evolved along with the technology. And I think that's really what has gotten it to the point now where we're thinking about it again in adults. Some increasing evidence in adults, which I'll share with you, but also the technology has dramatically evolved. So from these old roller pump that took up half the room, it sort of morphed into this homemade setup of people taking pieces of cardiac bypass pump materials and putting them together at the bedside and sort of jury-rigging something to now, which is what is this little box here that contains all of that stuff. And it's not only easier to use, but it's transportable. So again, the history of ECLS was fraught with the balance between bleeding and clotting. And we still struggle with that today, but it's much better with the newer technology. But in the past, frequent clots in the circuit would lead to complications, and also bleeding with very high levels of anticoagulation required would also cause problems. So there were frequent transfusions, and this is a cycle of sort of spiraling complications, and people were not excited about using it. So what's new about the new technology? Well, there's a much decreased surface area, and the new tubing is heparin bonded, and so it requires much less anticoagulation, and in some circumstances, particularly veno-venous ECMO, you can run the patient without any anticoagulation at all, which actually makes it an option for trauma patients. It's a compact design, again, easy to transport. The pumps have moved to the centrifugal pump. I'll show you what that looks like, but they require much lower pressure and much less hemolysis. The oxygenators become much more efficient. There's not a direct blood-gas interaction, which reduces the risk of air embolus. And the software design has dramatically improved such that it's much safer and easier for nurses to manage rather than having to have a perfusionist at the bedside. So this is the timeline of research, which I'm going to go into in some detail, but just to kind of give you an overview of how this has come along. So if you look, that first case back here was described in 1972. In the 1970s, there was an NIH-sponsored randomized controlled trial of ECMO and ARDS that was not very favorable. I'll show you that data. In the 80s, people were experimenting with extracorporeal CO2 removal. I'll show you some of that data as well. That continued into the 90s, and then in the 90s really is when the neonatal use really took off for extracorporeal life support. And so when did this all change for adults? It changed right around 2008, 2009, and that's why I tell you 10 years ago, which was 2006, I would have said you're crazy, right? But 2008, 2009, a lot of things changed. The new technology became more available. We had the H1N1 pandemic, which I'll show you some data from that. And the CAESAR trial was published, which I'll show you. And so where we are now is in a really dramatic phase of increased use in adults. And so here's some data from the ELSO registry. So the ELSO is the Extracorporeal Life Support Organization. And centers that do extracorporeal life support, including ours, become members of this organization and submit data to their registry. And so what you can see on the bottom graph here is the bars are the number of centers, and the lines are the number of cases. And if you just look at this kind of exponential growth that starts right here about 2009, really dramatic increase in the number of centers for adults in the US and the number of cases being done. What are the outcomes? I sort of circled them up here so you could see them for adults. So this is neonates, pediatrics, and adults. For adults, for respiratory failure, there are about 8,000 cases in the database. The survival to get off of ECLS is about 66%, and survival to discharge is about 58%. And for cardiac, it's a little bit lower, 56% and 42%. Now, those numbers may not seem great, but when I share with you the kinds of patients you put on who have a very high predicted mortality or who are essentially arresting, then these numbers start to look a little bit better. So this is the breakdown of use by age. And so again, the big bars here are the neonates. So again, lots of use in neonates. The dark bars are the pediatric patients. And then the light gray bars on the top are adults. So again, you can see here the dramatic change that happened right around 2008, 2009 with a significant increase in the amount of adult cases in the US. So let's go through some of the technology. So as I mentioned, sort of generation one was a homemade thing. You had to put it together. You basically took pieces of the bypass pump and put it at the bedside. It took up a big chunk of your room, and it required a perfusionist to manage it. Generation two, where we are now, is this little box on a cart, and you can train a nurse or a respiratory therapist to manage it. So what are the components of the system? Basically, the components, blood comes out of the venous system or the arterial system. In this, always comes out of the venous system. It goes through the pump, goes through a membrane oxygenator, and that's where, gas exchange occurs. It goes through a heat exchanger, and the heat exchanger is really valuable because the heat exchanger allows you to tightly control the temperature of the patient. So for patients that are hypothermic that you want to rewarm, you can rewarm them very effectively. For people you want to keep cold for whatever reason, you can do that as well. So here's the pumps. So the older pumps, again, were the roller pumps got reduced to smaller size, but they were still roller pumps, and they were still causing a lot of damage to the cells going through the tubing. These are the newer pumps. They're centrifugal pumps. They're run by a magnet. They're frictionless, and they cause, again, much less damage to cells. The oxygenators, so the unit that most people are using now is the McKay unit, and they make an oxygenator by itself. So the oxygenator and pump combined dramatically decrease the surface area, again, that you have to work across. The gas is basically blown over the membrane. It's usually oxygen, and that's called the sweep gas, and that basically the rate of that sweep gas is the minute ventilation of the patient. It's how quickly oxygen and CO2 are exchanged. So the heater exchanger, as I mentioned, lives right underneath it on the cart. You can take it off of that for transport, but it allows you to control the temperature, plugs into the bottom of the device here. This is the oxygenator with the pump right behind it attached to the magnet that runs the whole thing. How do you get it in and out? Obviously, you need cannulas in the patient. These are large cannulas. There's no messing around here. Your venous cannula is generally a 25 to 28 French cannula. And if you're going back into the arterial system, you're using an 18 to 19 French cannula in the artery. If you're using a double lumen cannula, which I'll show you in a little bit, those are 31 French. So they take a little bit of work to put in, and the safest way to do it is under fluoroscopy. The tubing is, again, heparin bioline coated, which minimizes the inflammatory reaction and also reduces the amount of anticoagulation. If your thing is working right, it should look exactly like this. So this is, blue blood coming out of the patient and red blood going back in. It's very obvious when it's working. You might wonder what this little thing is here. So this patient is cannulated in both the femoral vein and the femoral artery. And the femoral artery doesn't like those really large cannulas that much. So it impairs blood flow down the leg. And so you attach another cannula that you can't really see under him here, his pan is here, but that runs down the SFA that provides blood flow to the leg. And that strategy has dramatically minimized the risk of limb ischemia associated with the technology. Just another picture of the tubing setup in red coming in, blue going. There are internal sensors built into the device which give us a lot of information in the software package. It tells us the pressures that we're seeing both on the venous side, internally to the machine, and on the arterial side. It gives us a continuous temperature reading, and it also gives us continuous readings on SpO2, hemoglobin, hematocrit through a sensor as well. So it's really nice sort of continuous data that you get as well. So here's a setup for veno-venous ECMO. So there's two ways you can do that. One is to do a 2 cannula setup, which is the traditional configuration you're shown here, where you drain from usually the femoral vein, and you put back into the internal jugular vein. And that's a very common configuration. There is a newer cannula, however, which is a double lumen single cannula, so you can put just one cannula in the internal jugular vein and have the same effect. It's a much larger cannula, as I mentioned. It's about 31 French. It has double lumen, and it draws blood basically out of the SVC and the IVC, and it puts blood back in directed at the tricuspid valve. So it has to be very carefully positioned in the operating room, usually a combination of fluoroscopy and transthoracic echocardiogram. VA is generally done in adults through dual groin cannulation. In children, they'll use the carotid artery, but we don't use the carotid artery in adults because they tend to stroke for some reason. So they don't like that. So it's usually a dual groin cannulation. And again, this is a picture of that dual groin cannulation with the catheter that's coming off of it that's going down. You can see it better here into the SFA to provide perfusion. So what are the indications? So for veno-arterial ECMO, which is providing both cardiac and pulmonary support, it is most commonly used in cases of severe cardiac failure. Refractory cardiogenic shock, very little data in septic shock, although there have been a few cases published, But most of it is post-cardiac surgery support, post-heart transplant support. So if you've got somebody in the operating room, you can't get them off a bypass pump, you can put them on this and try to see if you can get their heart to recover. Full arrest or eCPR support, as I mentioned, is relatively new. The outcomes are not great. Survival's not great, and it's very logistically challenging. But there are places that are trying to do that. And in fact, in some places in Europe, they're trying to do it in the field because they send physicians out in the field on their flight services and so forth. Indications that we think are very useful for us would be massive pulmonary embolism, and I'll actually show you a case that we had in the last couple of weeks of that at Harborview with a good outcome, so I think I can show you the case then. And then hypothermic cardiac arrest, so if you're cold and you need to be rewarmed, people become very unstable when they're being rewarmed when they're profoundly cold. This is a way to support them through that. There are some toxic ingestions that lead to transient cardiogenic shock, like beta blocker overdoses, calcium channel blockers, and so forth, that we think are good indications because once the drug is metabolized, the heart should recover. And then there are some trauma cases where VA and ECMO may be indicated, particularly if you have to take out a lung. The important thing to remember with both of these, particularly VA, is it's really a bridge therapy. Right? It doesn't treat the underlying problem. It buys you time either for the underlying problem to get better on its own, like a myocarditis or something like that, or a drug to metabolize, or it is a bridge to something else. So you need to have a destination plan for these patients, particularly the cardiac failure patients. They may need to be a candidate for an implantable circulatory device like a VAD, or even for a transplant. And so it becomes a little bit more challenging to think about patient selection there because you need to make sure that either you're pretty confident they're going to recover or you have a plan for how to bridge them to something else. The contraindications, obviously, if you don't think they're recoverable or they're not a candidate for a transplant or a VAD, they probably shouldn't go on this device. You're going to be stuck. If they have other severe end-stage organ dysfunction, that's probably not going to get any better. And obviously, things like terminal malignancy, aortic dissection, those things are contraindications. And the eCPR people will say if it's more than 60 minutes of CPR, they won't do it either. And VA really needs to be anticoagulated. If you get a clot in a VA circuit, it's going to go right to the brain and cause a stroke. And so, in general, they need to be anticoagulated. So if they have a major contraindication to that, you shouldn't put them on. What about VV support? So VV support is all around severe ARDS, that consolidated lung that's all full of goo and you can't ventilate the patient, and PEEP isn't working, and you've tried everything and you're just really not making any progress. VV support provides just support for the failing lungs. The indications are generally severe refractory hypoxemia. We're talking about P to F ratios of less than 80 to 100. There's lots of things that can cause that: sepsis, trauma, burns, pulmonary infections, either bacterial or viral, smoke inhalation. So all of these things are options, and it's also used commonly in the lung transplant population, people who are already on a transplant list, to kind of bridge them while they're waiting for a lung to become available. So there aren't any absolute contraindications to VV ECMO, but there is good data around who doesn't do well. Generally, people who've been on a mechanical ventilation for more than 7 days do poorly if they've been on really high settings, and so we try to get to those patients earlier than that. If they got major immunosuppression, if they have an active CNS hemorrhage, all of these things are generally contraindications, although not absolute, because you can run VV without anticoagulation. So I think of VV ECMO as something in my toolbox for managing ARDS. Most people have it at the bottom of the algorithm right now. So you try messing with the ventilator, lung protective ventilation, you can try a variety of ventilator modes, you can try paralysis, you can try proning, you can try inhaled nitric oxide, and when all of these things are failing, people pull out the ECMO cart. I think in the future, it may move up to here, and we have a study ongoing right now that's looking at earlier intervention, because it really is a lung protective strategy, right? It is the ultimate lung protective strategy, because I actually can take them completely off the ventilator if I want, or I can put them on very low settings just to keep some alveoli open and let the lungs really rest. So here's the evidence in adults for respiratory failure. I mentioned that NIH trial. We'll go through some of these in detail, but the survival in that was dismal. It got a little bit better through the extracorporeal life support trials for CO2 removal, and then the real good data is in more recent times. So this is that first study, NIH study in the 1970s. There are 9 participating centers. They randomized 90 patients to ECMO versus conventional ventilation. Remember, this was all pre-lung protective ventilation or any of those things that we use now. But the survival was pretty dismal. It was 9% on ECMO and 8% on conventional. It was no difference, and people said this is a waste of time. And they're bleeding a lot. Mean blood loss was 1 to 2.5 liters a day. It's a lot of blood products to give to people who aren't going to survive. So we weren't too excited about that. In the 1980s, when people started to think about lung rest, there were a couple series published, again, looking at extracorporeal CO2 removal. This series had about 31 patients in it, and they were able to show, that it worked. The average blood replacement over the course of the run was about 1,800 cc's. How about the 1990s? So here was a randomized controlled trial of extracorporeal CO2 removal, and it was stopped early. So it was supposed to enroll 60 patients, it enrolled 40 patients, and the survival was better in the control group than it was in the therapy group. Not too much excitement there, and again, significant bleeding complications in the ECMO group. So this is the whole time period where I would have been saying, you're crazy, right? Don't do this. This is stupid. All right, well, now we're into 2009 with the H1N1 epidemic, which you might remember was relatively young people, a lot of postpartum women with very bad respiratory failure, very hard to support, hit Australia and New Zealand particularly hard. So there's some papers that came out of there. This was a case series of 68 of 201 patients who were treated with ECMO in about 15 ICUs in Australia and New Zealand. They had a mean duration run of 10 days. They had about 54% of them with hemorrhagic complications, but they were able to get a survival of 79%, which was really remarkable for this patient population. There's no control group in this series, obviously. The next paper that was published out of the H1N1 epidemic looked at 80 patients with 4 centers, and they were comparing patients who basically were referred to ECMO centers versus patients who were not. Most of the ones that were referred did go on ECMO. They tried to do a nice propensity matching and basically showed that the mortality for ECMO patients was 23% and the non-ECMO patients was 52%. So that was a pretty significant difference. Again, not randomized, not a perfect study, but suggestive of a benefit. Now this is the CAESAR trial, which is probably what gotten the most attention. This is a randomized controlled trial that was done in the United Kingdom. Enrolled 180 patients over about a 5-year period. This study also compared transfer to the ECMO center as the variable, so not absolutely ECMO versus not. And so about 75% of the people who were transferred to the ECMO center went on ECMO. 20% did not. Their 6-month survival for the ECMO center people was 63% versus 47% for the non-ECMO center people. But there were some issues, so it was significant. And they did a cost-effective analysis, and they did quality-adjusted life years. But the concerns were that the conventional ventilation group did not come to the ECMO center, and so maybe wasn't treated the same from a ventilator standpoint. And they weren't able to transport people on ECMO, so there were some people who actually died in transport. So it's a significant finding, but people are still a little critical of those issues related to the trial. So the trial that's ongoing right now is called the EOLIA trial. It's a multi-center trial being largely conducted in Europe. They're trying to compare what they call best ECMO care versus best conventional care. So really controlling very tightly the treatment that the control group gets as well. And they're trying to intervene earlier. So it'll be interesting to see the results of this. I think it will help us sort of figure out whether the CAESAR trial findings are really real. What about trauma patients? So I'm a trauma surgeon, so I was out there looking for the data in trauma patients. It's not very good. There's lots of opportunity here. There are 26, this study was 26 ECLS patients, and they compared them to 76 patients with respiratory failure at a different trauma center. They tried matching them, and they did show, a suggested and benefit in survival when they matched the cohorts. Again, small numbers, not the same trauma center, not randomized. But there have been several case reports out of trauma centers saying that VV support off of anticoagulation is safe. This is some data that was shared from Oregon Health Sciences University. My colleague down there was in the military, David Zones, and he shared this data with me looking at the military's experience with ECMO, and they were transporting patients from Landstuhl to the US with bad respiratory failure on ECMO. You can see these are all relatively young people with very bad traumatic injury and very high injury severity scores, and all but one survived. So again, some data to suggest may be useful in our population, but we really don't have randomized controlled trial data. Some data out of Europe, again, looking at trauma patients with severe thoracic trauma. A mean ISS was 58.9, which if anybody knows what the ISS score, that's really super high. That's really high injury severity. 75 is the highest you can get, and all those people die. And so the mean time to put them on ECMO was about 5 days, which is good because you want to get them on early. They had about a 15% procedure-related complication, primarily bleeding, but only needed 3 units of blood over the entire ECMO run, which is remarkable compared to the historical data. And this is, again, from that study. ECLS, really responded, the patients responded well to it, and 85% of them were able to wean from it, and overall survival was 79%, which is pretty remarkable. So there's suggestive data out there of benefit for the patients that I take care of every day. So what about other indications? So I showed you a whole lot of indications. What's the data? It's not very strong. So the only randomized controlled trials are what I've shown you in ARDS. Everything else are essentially cohort studies or case series. And so we don't have strong evidence, if you want to do an evidence-based guideline for any of this, but I'm going to share with you what we have. So for acute myocardial infarction, there was a before and after study that was done looking at patients who were in the cath lab getting percutaneous coronary intervention, and the patients that were treated with ECMO in that situation had a better 30-day mortality, about half of what the people who were treated without ECMO had. Again, time periods were pretty wide. There were some issues with, even coronary stents weren't available in some of the earlier time periods, so it wasn't a perfect study. There's been some case series on fulminant myocarditis, which tends to be recoverable, where ECMO was compared to VAD and appeared to be as good and less invasive. Pulmonary embolism has gotten a lot of attention. Again, a lot of case series retrospective reviews, but pretty impressive survival for massive PE with hemodynamic instability, including patients who've had cardiac arrest, reporting survival rates of 62 to 70%. So I'll show you a case of that in a little bit, but I think there's a lot of promise there. And then ECPR, which is generally showing survival rates around 29 to 30%. Most of the data is on in-hospital witness cardiac arrest. Out-of-hospital cardiac arrest is a whole other can of worms, but there is one paper showing a survival advantage there as well. And then hypothermia, I talked about rewarming. Again, only case series in the literature, nothing else than that, but we currently try to use cardiopulmonary bypass to rewarm. This is probably better than that. And there are cases locally where we have survivors for deep hypothermia. These were some kayakers that went into the bay in April of 2015. They were taken to Tacoma where they were resuscitated, and they called around trying to find ECMO and ended up having to fly them all the way up to Bellingham to get ECMO. So we think there's a community need for this that Harborview can fill. So what is the current status of ECMO at UW Medicine? So UW Medical Center has actually had a program for a few years now. They are primarily a VA program in conjunction with their cardiac surgery program and for the heart transplant patients. They do use veno-venous ECMO for bridging the lung transplant population, and they are working on developing a cardiogenic shock program that will be a bridge to VAD. They have, again, been focused very much on their niche population and have not been taking transfers from the community for this issue. The Harborview program is focused primarily on severe respiratory failure and providing VV services for that population, and we will take transfers for that. And so we are working with the community on trying to make them aware that we have it and get those patients in earlier. Again, we think even if they don't end up going on ECMO, transfer to an ECMO center is beneficial because you have other people there that are really interested in the disease and have a structured approach to managing it. And then we have VA also capability for specific indications. Our specific indications are the hypothermia patients I talked about, massive pulmonary embolus, which is important to us as a trauma center. It happens to our inpatients a couple of times a year. Myocarditis or blunt myocardial injury, which should recover if you can bridge them. We've tried in the past bridging them with things like balloon pumps and things, and this is probably better than that. Certain trauma patients who need lung resections, and then specific toxicological ingestions that I talked about. And this is a list from a poison center folks about toxicologic injections that they think would benefit from ECMO. Again, only case series data out there, nothing dramatic. But in consultation with a toxicologist, we would consider it for these patients as well. So for respiratory failure, again, we're following basically the ELSO guidelines. Severe hypoxic respiratory failure, PDAF ratio is less than 100. Hypercarbic respiratory failure, pH is less than 7.2, all despite maximal support. And what we've done is brought together a multidisciplinary is the word I want, multidisciplinary group who have worked on developing an institutional respiratory failure pathway so that all the ICUs in the institution will have the same approach to respiratory failure and have sort of a pathway to work through of evidence-based things to try early on, and if they're failing those, then to get them onto ECMO before they're too far out to benefit from it. We've done the same thing with pulmonary embolism to try to develop a pathway again so people know when to think about this approach. I'm not going to spend a lot of time on these, but just to show you that there are a couple of really interesting websites if you're really nerdy and you want to take a look at these. These are scores that have been developed. These are online calculators for them for predicting whether the patient's going to survive when you put them on ECLS. And so there's one for respiratory failure and there's one for cardiogenic shock. They're useful sort of decision-making tools when you're trying to decide if your patient's a good candidate or not. It asks you a bunch of questions, you have to fill in some data, and it gives you a number, and it shows you on a graph based on the ELSO registry where your predicted survival would be. All right, what about the complications? So they're better than they were in the past, but they haven't gone completely away. There are certainly mechanical complications that you can have, problems with the cannula, problem with the pump, clot in the oxygenator. These are more common actually in respiratory failure than adult cardiac failure, and that's because you spend longer on the pump in respiratory failure. Respiratory failure patients generally spend weeks to months on the pump. Cardiac patients are usually sorted out within a week and go on to something else or they die. When you look at bleeding complications, they tend to be higher in the cardiac patients, again, because they require more anticoagulation. This is all data from the ELSO registry. And of course, neurologic issues can be a problem in both groups and can be a fatal problem in both groups. Sometimes it's an underlying neurologic issue you couldn't identify because when you got them, they were on paralytics and on high ventilator settings, and you couldn't really assess them, and you get them all settled out, and then you find out that they're neurologically not salvageable. Renal failure, very common. I think that's more of a reflection of the underlying disease that they're dealing with than the therapy itself. And the same with the need for inotropes and so forth. Other pulmonary complications you can have is pneumothorax, again, more common in the respiratory failure patients. Infectious complications just because they spend a long time in the ICU. Everybody's at risk for that. And limb ischemia has pretty much gone away as long as you routinely use that limb perfusion cannula that I talked about. So I think from a lab medicine perspective, I was trying to make a spin on this for you. I think the big yin-yang is bleeding versus thrombosis, right? In general, we prefer to have these patients anticoagulated unless there's a reason not to. Heparin is generally the standard. Some people will add aspirin as well, but heparin is generally what's used for most patients. You can use direct thrombin inhibitors as an alternative if they have HIT or something like that. There's a lot of variability in how people manage the anticoagulation. Most people are using ACT when they first cannulate in the operating room because it's readily available, has a quick turnaround time, and you can be sure you've got your bolus has worked. For long-term management, most people are using PTT in our sort of standard anticoagulation algorithms that we use for lots of other things, 1.5 to 2 times normal. Of course, the balance of more anticoagulation is that you have less clot in the circuit and less anticoagulation. Well, you have surgical bleeding and so forth. So the good news is that for VV ECMO and for the trauma patients that we've done, we've been able to run them safely as long as our flows are good off of anticoagulation for long periods of time to sort of deal with some of those complications. What's the transfusion management? So most people keep the PTT 60 to 90, or if you're using ACT, you can keep it at 180 to 220, or you can use 10A. So there's lots of variability in how people monitor things. We're generally using PTT because it's simple and we're used to it. In general, though, you want to keep everything else normal. You want to keep your platelet count normal. You want to keep your other markers of coagulopathy normal, your INR, your fibrinogen. If you have fibrinolysis, you want to treat that. So you don't want the rest of the coagulation system to be out of whack. And then transfusion generally has to be a little bit more liberal in the VV patients. They have some degree of recirculation, and so if they don't have a higher hematocrit, sometimes they won't get adequate oxygen delivery. So our TRIC trial patients are really not included here. And then if they're requiring escalating doses of heparin, we think about antithrombin 3 deficiency, which we would treat. And then hemolysis is pretty rare in the modern circuits, but we do watch for that. So I want to just share with you just a couple of unique ECMO complications. I think I have enough time here that are kind of interesting. The most common complication on VV ECMO would be recirculation. And what that basically means is that some of what you're putting in is coming right back out the other cannula. It's not really affecting the patient. That is most commonly a problem with the cannulas being too close together or not positioned properly. And so it requires that you adjust to the positioning. The way you know that it's happening is that your SVO2 on the machine is going to be high, but the patient's arterial sat is going to be low. So the machine is getting oxygenated very well, and the patient is not. So it requires a little bit of fiddling to fix that. VA has a couple of other unique complications. There's this thing called north-south syndrome, which is kind of interesting. So if you think about it, you're putting your blood back into the femoral system, and it's coming up the aorta here, and it's mixing at some point with what's coming out of the native heart. Now, if the native heart's not working very well, you're doing most of the work, then you're getting plenty of oxygenated blood way up here to these important vessels that go to your head and neck, right? But if your heart is recovering and your lungs are not, right, then you're getting deoxygenated blood out of the heart, and the mixing cloud gets pushed further, and so the upper part of the body gets relatively ischemic. And that's why it's called north-south syndrome. We monitor that by monitoring the right radial arterial line, and if that's going down, that suggests that they have that. So you're perfusing the legs great, but not the head, and that's not good. And in that circumstance, you would generally switch over to VV ECMO to continue to support the lungs, but to take away this issue of north-south syndrome. The other thing that becomes a problem in patients with bad cardiac failure on VA ECMO is ventricular distension, because ECLS is basically partial bypass, but they will continue to have some pulmonary blood flow. And so if the native heart is not ejecting at all, it will get distended. And distended hearts are unhappy hearts. And so they form clot, and it can progress, make their cardiac failure worse, and they can actually back up and cause pulmonary edema or pulmonary hemorrhage. So we do daily echoes on these patients. We try to run the flows low enough that we're still getting some pulsatile flow from the heart. And there are some interventions that you can do if the LV becomes dilated. Those include either an operative vent, which is really not an issue for us, but for cardiac surgeons it is. You can switch them over to a tandem heart cannula, or you can do a balloon atrial septostomy, basically poke a hole in the atrial septum to decompress the left ventricle, and that works pretty well. Impella is also an option that we have. So the bottom line is that I think this is really a multidisciplinary effort. It took us about 1.5 years to get this program to the point where we were ready to go live, because you need everybody on the same page, and there's a lot of resources that go into caring for these patients. We've had, I would say, outstanding support from our surgical subspecialists in vascular cardiothoracic surgery. We've had really great interactions with the pharmacy, with the lab, with the cardiologists, and so a lot of work has sort of gone into putting this together. We also did spend 1 year training our nurses and physicians to be specialists in managing this, because we don't have perfusionists at Harborview to help us out either. So it requires continuous training. We have continuous competencies for the nurses and the RTs who are ECMO specialists. We have a simulator that they can train on, because again, these are not common cases either, and we need to keep them proficient. The logistics at Harborview, this program is run by the trauma faculty. We're in-house 24/7. You really need an attending level person in-house to manage these patients. And so they're managed in the trauma ICU. There's a 2-to-1 ratio, so that for every patient there's a bedside ICU nurse as well as the ECMO specialist. So again, fairly labor intensive. We have 3 pumps at Harborview, so we could run 2 patients 24/7 and have a backup pump. So again, resource limited. So you want to be selective. You don't want to put somebody on who's going to be stuck on for a year without an endpoint. And then we've had great support, as I mentioned, from our subspecialists. It's really a multidisciplinary team, put together protocols, checklists, standardized documentation, order sets. This has been a real lesson for me in building a program like this. But the institutional protocols around hypoxic respiratory failure and pulmonary embolism have been really valuable, I think, in improving the care overall, in addition to having this program. Again, these are high-level, complex patients who are not involving the residents in their care, so that puts the work on the attendings and the fellows. We have routine involvement of palliative care. We've developed family education materials, and then we have the ongoing training. So our program went live April 1st of 2016. We are 6 months old. So here's the experience so far at UW Medicine. I only have the data for UW-MC through 2015, but between 2012 and 2015, they did 41 cases. 31 of those were VA, again, cardiac surgery patients with a 52% survival. And then they had 10 veno-venous patients, all of whom were transplant patients, all of whom went on to transplant with an 80% survival. At Harborview, we started again in April. We've had 3 VV cases. 2 of those were trauma patients. Again, that reflects the types of patients we see. 1 was a medical patient with viral pneumonia. 2 of the patients died. 1 of the trauma patients and the medical patient died from underlying neurologic issues not related to the ECMO. And then we had 1 trauma patient who survived after a 2-week run and was weaned successfully off of ECMO and is now in rehab. And we have 1 VA case, which is interesting, of a massive P that I thought I would share with you. So this is a 55-year-old gentleman who came to the emergency department with 3 days of worsening shortness of breath. He was tachypnic, respiratory rate of 30, agitated. His oxygen saturation was about 95%, but he was on a non-rebreather. This is his chest x-ray in the emergency department. You can see a pretty big dilated heart here. You can see they're worried about him because they got a defib pad on his chest, right? But big, wide, dilated heart. But lung fields are relatively clear. No real reason for him to be hypoxic. He's also hypotensive with this pressure in the 80s, in atrial fibrillation, and a heart rate in the 120s. He had no past medical history. Denied any cardiac disease, lung disease, or anything. He had to be intubated fairly rapidly in the emergency department. This was his first blood gas after intubation, so fairly severe metabolic acidosis, as you can see there. So they were concerned, and they sent him to the CT scanner with a differential of pulmonary embolism versus aortic dissection. And this is, I think, a pretty good CT scan of a saddle embolus. So I gave you 2 cuts here. This one you can see, this is a pulmonary artery here filled with contrast. You can see this embolus here coming up almost to the bridge there. And if you go to the other side, you can see a almost completely occlusive embolus on this side. So then he's in the CT scanner. Now his blood pressure is 50. So they started him on pressors. They bolused him with heparin as soon as they saw that CT scan, started him on an infusion. Took him to the interventional radiology suite to attempt some catheter-directed thrombolysis. In there, he had a couple of short cardiac arrests, 2 to 3 minutes, and came back, and then had a 3rd arrest, at which time they called the ECMO team. We came and put him onto VA ECMO, which stabilized him very nicely. He had a 6-day run on VA ECMO. He continued to get treated for his PE. We re-imaged him about 5 days later, and he had a 70% reduction in his clot burden, and his cardiac function slowly improved over time to the point we were able to wean him off of ECMO on just dobutamine. And he is now extubated, still in the hospital, but doing quite well. So I think that's a good example of the type of patient that can be rescued with this therapy if you know you're buying time to do some other intervention. So in summary, I think what I've shown you is there's exponential growth in adults. I think the reasons for that are the technology changes and the data that we have now. We still have a lot to learn. If you want to build an academic career, there's a lot of opportunity here to study this problem. Patient selection is absolutely critical. The randomized controlled trial evidence is limited, but I do think that as long as we carefully build regionalized centers with expertise in this area, I think there's benefit for our adult patients. So again, I want to thank you so much for the opportunity to come. I think we have a little bit of time for any questions.
Thank you.
Yeah.
Hi, thanks. That was a great talk. I have a couple questions. The first one is, in terms of resource utilization, is there any data these days on what ends up being the average sort of cost per quality adjusted life year for this compared to other sort of what I imagine are fairly expensive interventions like transplants and things? And then the second question is, I'm responsible for the lab testing in Airlift Northwest. I was once asked if we could support the anticoagulation testing to support ECMO or something like that in the air. My question to you would be, is the technology, I mean, is this something you would want to do in a tiny little helicopter or a Learjet 2 hours from anywhere? Is it ready for airplanes?
Yeah. So there's two separate things there. So the first one, the only cost quality of life data that I know of is the stuff from the Caesar trial, which was about 19,000 pounds, it's British, for a quality adjusted life year, which I guess is a reasonable number in that circle. But I don't know of any other data related to that. And that's for respiratory failure, not cardiac failure. As far as transport goes, I do think that's in the future as well. Some of these patients are really too sick to move, right? So if you're getting a call from an outlying hospital and the patient's too sick to move, what do you do, right? So many places have built teams that will go out to that hospital, cannulate the patient, stabilize the patient, and bring them back. Now you can imagine that's logistically challenging. It requires manpower, it's expensive, but it's an option. And these machines are very transportable in a small space like a helicopter. So it's feasible to do that. It's really more our working out the logistics of who we would send out. And then you also have credentialing and privileging, and if you go out another state, then it's a whole licensure issue, right? So there's all those issues to sort out. But there are places that are doing that.
You had mentioned that it potentially could be used for inhalation injury. I just wondered if your burn surgeons have tried this yet?
They are interested, and they have taken the training, and we are waiting for them to find the right patient. They have not tried it yet. But there is interest, and there are some small case series in the literature. Yeah.
Thank you for coming to present to us today, and congratulations on setting up your new service. You mentioned that this ECMO has been used occasionally in infection, and I was wondering why there aren't greater numbers of that. Is it a logistics issue, access issue, or is it because perfusion failure results from a completely different mechanism, so it's just not, it's not really a treatment of choice?
Yeah, I think that it's probably more that. So you're talking about septic shock treatment, right? So again, it's not treating the underlying problem. So if the underlying problem is not under control, you don't have source control, whatever, it's not going to fix that. And then I think the distributive shock of vasodilatation and stuff is not treating that either, right? So if they had primary cardiac failure from their sepsis from a bacterial toxin or something that caused cardiac depression, it might help with that. But the underlying problem is probably down a path that's too far along to really make a difference. So we have not played around with that in that population, again, because it's a limited resource and we don't want to stretch ourselves into someplace where we're stuck. Maybe in the future we'll have a better sense of that, but right now there's just not enough data.
So I wondered also if you'd comment a little bit about, you mentioned a study that wasn't perfect, but the use of ECMO for patients getting cardiac bypass surgery, but you noted that that stents weren't available prior to 1998, and I just would like to hear your brief comments about that, simply because my non-cardiovascular surgeon opinion as a laboratory medicine guy is based on people in my age group, the use of stents is increasing in use in our population.
So that study was actually a cath lab study. It wasn't a cardiac surgery study, but it was a study with cardiologists who had a patient in, profound cardiogenic shock in the cath lab trying to do an intervention on them. And they have cases where they have bridged patients on ECMO to get to PCI and stents. The challenge with that study was they were comparing before and after, right? And the before period had time in it that they didn't have the stents that they have today. So we don't know that the outcome was solely due to the ECMO versus something else. But there is interest in that, particularly in our heart failure cardiology group here at the university in figuring out a capacity to be able to bridge patients, who are in a cath lab with this therapy. But again, it's important that they have an endpoint. So it's easier for them to implement that here than it is for me at Harborview, because I don't have VADs and cardiac surgeons. And so if I did it, I'm going to have to transfer them here. And they have to be able to take my transfer, right? So we're trying to help them build that program here first and see how it works before we would do that at Harborview. Yeah.
Thanks a lot. So you opened with some data from the registry, which was fascinating, and it must be tempting to try to ask all kinds of questions using that data that maybe one shouldn't ask because it's not a trial. Mm-hmm. Have you been involved in any conversations about how to make that registry data as useful as possible for comparing across institutions? Yeah,
it's a great question. I think there's a lot more that could be developed with the registry. The ELSO organization is actually relatively young. It's housed at the University of Michigan, no surprise there, right, as the founder of ECMO. But it's relatively young. It doesn't have a easy data interface. And I think all the centers are pretty reliably submitting data to it, but I don't think that they even have a lot of information on the centers themselves to compare center variability and stuff like that. They do have an annual meeting, and I think there's been a lot of discussion at that meeting about how to bring it up to that level. Certainly people are publishing papers out of it, but they're very descriptive. Yeah.
Okay, well, thank you, Dr. Bulger.
Thank you very much.